Let's get the latest on vaccine therapies and the rest of the coronavirus developments. Joining us tonight from the White House Response Coordinator, Dr. Deborah Birx. Dr. Birx, thanks for being here.
Thank you.
We have a lot of questions for you, a lot from viewers. But right now, there are a lot of people afraid. They are uncertain. They are facing a school year, many parents wondering what's going to happen. Tonight, where is this virus in your mind? We just heard the president, but from you, the medical expert, where is it?
So this particular pandemic that we're experiencing across the South, the Southeast, and into the Southwest and West is very different than what we experienced in March and April. What do I mean by that? This epidemic all appeared across the South and the West after June 10th, simultaneously. Previously, in the March-April timeframe, first we had the New York Metro following Washington State, and then a series of metros that went down in a period of time, often 2 or 3 weeks apart. This time we saw wide virus spread across counties, across rural areas, across small metros and big metros, all the way across the South, Southwest, and West, almost simultaneously. So this was an event that we think can be traced to Memorial Day and opening up and people traveling again and being on vacations. And then we're really tracking this because where it hasn't happened yet is our Midwest and our Northeast that was so hard hit in March and April. And so we're watching that very carefully.
What's the top stat that you're following? What are you looking at day to day, the top statistic that you're looking at?
So we send a report every week on Mondays to every single governor. It's about 10 pages per state. And it really goes into detail. What we think is the most sensitive indicator is what we call test positivity. And it only has to go up a tiny bit. So let's say you had 3% test positive, and then the next week you have 3.3%. That is when to start really watching. We think that's the earliest indicator. That's why we show that at county level, at metro level, at small cities and large metro areas, as well as the state level, so that every governor and every mayor and every health commissioner can really understand what we're seeing in their state, and so that we can really provide recommendations to the states on how best to control this virus.
Well, speaking of testing, the president mentioned it, but you're at over 50,343,000 tests. Positive tests reported about 4,653,000. The percentage of positive tests, 9%. Here's the question, though, that we're getting a lot, and that is the time it takes to get the tests and the results from the test. If it takes 1, 2, 3, even 4 days, what's the purpose of the test from a medical contact tracing possibility?
So you're absolutely right. The turnaround times, particularly across the South, are too long. We've been working at state-by-state levels to, when the president talked about a change in strategy, really increasing our strategy. We, of course, have a testing strategy, but really to address these turnaround times will be absolutely critical. And then the most hardest hit states, they are having the longest turnaround times. How did this happen? Well, if you look right now, and you had it on just before, we have 3 states that are equivalent to what the worst conditions were as far as number of tests required was New York. And we have 3 states approaching those case numbers. So now we need 3 times, really, the number of tests that we had before. And so we're really working to increase pooling. We know that can dramatically increase our throughput. Really, we need the Northeast and the Midwest that have those very low test positive rates to move to pooling so that those tests can be moved to the South, the Southwest, and the West. Just like early on, we shifted a lot of testing into the Northeast. We need the Northeast now to help us by doing pooling. They have test positivities often under 3%. We think they're in the perfect situation to combine 3 or 4 different tests into one tube to run it, and that increases our capacity by 4x. And so this is what we're really asking each of the states to work on, to do. We're asking the platforms, the Roche and LabCorp and Quest and other large commercial labs to really look at pooling in the Midwest and the Northeast so that we can make more tests available to the South and the Southwest.
But is it fair to say that that is a national failure, testing? Here, back in March 13th, here's what we were saying back then, you were saying from the briefings back then.
Clients and patients and people of interest can go, fill out a screening questionnaire. They would move down this and be told where the drive-through options would be for them to receive this test. The labs will then move to the high throughput automated machines to be able to provide results in 24 to 36 hours.
And that just did not materialize. How come?
So that did materialize all through May and the first part of June and almost to the end of June. We had turnaround times in less than 24 hours to 48 hours when you include the fact that we had to ship the samples. So the drive-thrus were working, the pharmacies, and we had multiple sites across the United States. We had point of care available throughout the United States. But when you have this level of outbreak, and that's why I wanted to start that way, we have almost 70% of every parish in Louisiana with a test positivity above 10%. We have almost 65% of all the counties in Alabama and Mississippi. I was just in the field at all of these 9 states with these recent outbreaks to really understand what they are facing. This is a very different epidemic than we had in March and April, and it will require additional tests. And so this surge and this degree of cases so widespread compared to previously does have to be addressed. I think that's what the president is talking about when he talked about yesterday, increasing our tests and having a strategy that surges tests into the areas so we can really decrease those turnaround times. We know how important those are. We know how important it is for everybody to know immediately whether they're positive or not, so they can be isolated and prevent further transmission.
Dr. Birx, we have some specific tweets and Facebook posts from viewers. If you just have a couple more minutes on the other side of a break, we could ask those to you.
Perfect.
Okay, we'll see you in a little bit. We're back with Dr. Deborah Birx about the latest on the coronavirus. Thanks for sticking around. The president just said this. He was asked about schools reopening and about kids and infection rates. Here's what he said.
We understand that the children who go to school then go back to home, they're with, some live with their grandparents, that there's a real risk. Would you understand if some schools...
They do say that they don't transmit very easily, and a lot of people are saying they don't transmit, and we're looking at that. We're studying, John, very hard, that particular subject, that they don't bring it home with them. Now, they don't catch it easily, they don't bring it home easily, and if they do catch it, they get better fast. We're looking at that fact. That is a factor, and we're looking at that very strongly. We'll be reporting about that over the next week.
So is that right? Is that what you're looking at? I mean, what do you know about kids and transmitting or kids and getting it?
So that's a really key question. The best study out so far is a study from South Korea that looked at children under 10 and children over 10. And I think what we need to do and what we're really trying to do right now is to really look at what the antibody levels are already in children under 18. So we're launching a very large sero survey across all age groups to really understand where has this virus been, who has is infected, who is infectable, and who is transmitting the virus. And so I think there's still open questions there, and that's why the president concluded with, we're studying this very hard. I think it's a very important question that we have to understand. Do children under 10 transmit the virus less? That's what the South Korea study suggests, but I think it really needs to be confirmed here. I think that's the kind of questions that have to be critically answered. And I think the multi-generational household question is critically important. I come from one of those multi-generational households. I have a 96-year-old and a 91-year-old mother and father that I'm always worried about and protecting. So I don't even see them. So I understand.
But I guess parents want their kids to be studying in school, but this is a crucial question. We're almost coming to August. These schools are making decisions about what they're going to do. This seems to be kind of a linchpin as to whether they're going to open or do distance learning. I mean, what is your recommendation?
I think there's 3 pieces, and I think the CDC has put this out quite well, and I think the president will talk about schools again sometime this week, and the CDC will put out additional recommendations. I think it's a very important point. Children that have pre-existing conditions that we know are susceptible to the virus, they probably should not be in an in-school situation where there's active virus circulating. Teachers that have what we call pre-existing conditions that put them at a higher risk for more severe disease, they have to be accommodated. And then the majority of the children, what is their risk? We know from data today that children do quite well with the virus. So if we protect the teachers, we have teachers in the classroom that are protected through innovation. Some people are putting up plastic shields. Of course, many schools are having children and teachers in masks. We know all these things work, and I think it really requires school districts to plan and be flexible and put the child at the center to decide what is better for the children of America and what's best to protect the children and their household at home. And everybody's going to have to work through those very specific issues.
Okay, a couple of viewer questions real quick. These two are related. Benji, for Dr. Birx, we are hearing reports that antibodies are not lasting long post-infection. How does that change the game for vaccine development? Are there statistics on reinfection? Same question. Josie says, if you've tested positive, whether full on symptoms or asymptomatic, can you be reinfected? Do we know the answer to that question now?
So, great immunologic questions, and I trained in clinical immunology, so this is an important question. So the first question about persistence of antibodies. Even when we're vaccinated, our antibodies wane. They decrease over time. That's what antibodies are supposed to do. But there's another part of the immune system, what we call the memory part of the immune system, and the cellular arm of the immune system. So when you ever encounter that virus again, those antibodies and that immune response immediately surge. So what used to take you maybe 10 to 14 days to develop now appears in 24 to 48 hours, allows you to re-clear that virus. And so that's what happens with other viruses and other infectious diseases. I think the question about can you be reinfected, you know, we have a lot of cases out there, and we have a lot of cases now over the last 6 months, and we don't see this high level of reinfection. What assures me is we know that people, the majority of people around the world, once they're infected, they mount an immune response, both what we call the antibody response and the cellular response, and they clear the virus. That is the roadmap for vaccine development. That's the roadmap for monoclonal antibodies for therapeutics. And I think that's what's so encouraging about this virus and our ability to clear it.
Two more things. One is the New York Times had this massive piece in which they have this sentence. Inside the White House, Dr. Birx was the chief evangelist for the idea that the threat from the virus was fading. Did you read that piece, and what'd you make of it?
So I'm a data person, so I went back to that very specific day. I report out the data every single day. So I went back to that day and I looked at my report. And my report started out with, we are seeing improvements in New York and New Jersey, but we're seeing increasing concerns and we're not at peak in Boston or Chicago. We have new concerns in Houston, and we have new hotspots developing in Washington, D.C. and across the South. So to me, that's a very balanced report. That's what epidemiologists and data people do. They just put the data out there as it exists. I was surprised by the piece because most people will tell you that I err on the other side, that I am too forceful and too direct often about the data and what it's showing. And I've never actually been called an optimist in that way before. So.
Well, last thing, another report in a Washington Post piece said Birx and others were frustrated with the CDC's antiquated system for tracking virus data, which they worried was inflating some statistics, such as mortality rate and case count, by as much as 25%. There's nothing from the CDC that I can trust, Birx said, according to two people. Is that true? And where do you think the CDC data is today?
So those are two pieces put together. So what is CDC extraordinary about, and what are we using every single day? Their surveillance data, their epidemiologic data, their laboratory data, and their integration of all of that data, and the analysts that are down there as epidemiologists and analysts that provide those reports. I rely on those. That data is all superb. That comment was about daily hospitalization data. When we were first trying to put out remdesivir, it's important to me that there's extraordinary equity in how we distribute medication when it's needed for really a very specific patient. And so we were having a really passionate and compassionate discussion about what's best for patients, and we were talking about the hospital data and the importance of daily complete reporting. And that's what we were talking about, is the hospital data specifically. The epidemiology data, the surveillance data, the influenza-like illness surveillance data, the emergency room syndromic management surveillance, all terrific, critical, and it's not just the data, it's the people they bring to the table to analyze it.
Dr. Birx, we kept you too long. Please tell the White House we apologize, but we appreciate your time, and you're welcome back anytime, because our viewers have a lot of questions, as you can imagine.
Thank you.